Welcome back, everybody. In this episode, we're going to be discussing a paper that looks at an unusual case report on papilledema. I'm Dr. Mika, and our guest expert for this episode is Dr. Kuniyoshi Kanai, who is the residency director at Berkeley Optometry and chairs the Academy's Fellowship Engagement Committee. Welcome, Kuni.
Thank you, Mika, for inviting me over.
So this paper is entitled Case Report, Papilledema Secondary to Cerebral Venous Sinus Thrombosis After Severe COVID-19 Infection by Smith and colleagues, which was published in the Academy's journal, Optometry and Vision Science. Now, this paper goes over a rare complication of COVID. So really, let's talk about papilledema first, because I think it would be good for us to all have a refresher before we go into like the nitty-gritty details of what happened to this poor patient. So can you tell us a little bit about papilledema?
Yeah, sure. Papilledema is a specific term reserved for disc edema caused by the raised intracranial pressure and not by the other cause. And we, as a clinician, may have suspicion of papilledema in your patient that sits in your chair in the office, but ultimate diagnosis can only be given after proper workup in the hospital setting. And depending on your suspicion, some patients you may refer to primary care provider and coordinate the care through that. Or some cases, you might end up sending them to the ER.
Yeah, so I've had to send patients to the ER for presumed papilledema in the past. And it's one of those things where I know I shouldn't use the term papilledema because technically I don't know if their intracranial pressure is raised yet. But what I find is in the notes that I send with the patient to go to the ER, if I write that word papilledema, then when they go to triage, they get care much more quickly and they're not sitting around waiting for as long. So what are some symptoms of raised intracranial pressure where maybe we can feel a little bit better about using that term?
Yeah, and obviously those patients tend to have a lot of headache histories, and those patients have pulsating type of headache over time, and that tend to get intensified toward the day of diagnosis. And the transient vision loss seems to be common, and because of the pressure compressed against the posterior ciliary arteries. And just like AION patients and NAION patients, they have transient vision loss, and that people may describe as the graying or discoloration of the vision that lasts only a short period of time, and maybe up to a minute, and with the complete resolution afterwards. Another common one is those whooshing sound, tinnitus, and pulsating tinnitus. And this is actually related to relevant in this case that we read, that the patients may have the cerebral venous thrombosis or stenosis. And oftentimes it happens in this area, this transverse section that's relatively close to the ear, and the lumen of the venous system gets really narrow and tight. So that creates the turbulent flow that will be, that will give the patient sensation of this odd sound. It could be shh, shh, or even a high-pitched sound. So those seems to be a relatively common problem. And some patients may have intermittent diplopia, just like this patient in this manuscript. It is the compression over the sixth nerve. And as we all know, that sixth nerve travel from far away to get to the EOM. So along the way, particularly the petrosus portion of the temporal bone, it makes a little kink. That little kink compression due to the intracranial hypertension may cause those intermittent diplopia. And lastly, some patients may complain about this shooting pain that radiates from the spine. And this is also the compression against the nerve root. And that pain will start from the spinal area and shoot down the extremities like arms.
Okay, so let's segue into our case now. This patient was so sad. He was only 29 years old. He got COVID-19, and his only risk factor for severe disease was obesity and a history of asthma, but he was otherwise, before his infection, in good health. And he was already hospitalized, but due to his symptoms, a bedside exam was ordered, which showed bilateral optic nerve edema, but they chose not to do a lumbar puncture in his case. Can you explain to our audience why that happened?
Yeah, this is very interesting that they end up not pursuing it for good reason. Poor patient that he went through a lot and intubated and eventually developed the hypercoagulative status and suffer pulmonary embolism and put on the blood thinner. And then patient developed the subarachnoid hemorrhage. And so all of those major complications that he needed to go through, we can understand why neurology team felt a little bit hesitant to move on and do lumbar puncture. But meanwhile, he has already gone through the MRI, MRV, the venogram, and that showed the cerebral venous thrombosis. And there's a huge correlation between the cerebral venous thrombosis and intracranial hypertension, because the cerebral venous system actually drained the cerebral spinal fluid. So it's very understandable that they made this assumption and presumed diagnosis of the intracranial hypertension, and which turned out to be true. And acetazolamide 1 gram eventually made the patient's papilledema substantially improved.
So I personally don't work in a hospital setting. I'm a primary care clinician, optometrist. So does this case offer me any insights that I can take back to my practice?
Absolutely true. And you're all right. We are outpatient clinicians, and many of the primary eye care providers are like that. And we don't practice in a hospital base in an inpatient situation. But several clinical tips I think that this manuscript provide. Number one, look at the mail too. And when we encounter patients with the papilledema in an outpatient setting, and they are not that symptomatic and often associated with the idiopathic intracranial hypertension, and when you look at the profile, almost they are predominantly female. But male can have something like this too. And when I look back, after I read this article, I thought about my patients in the past. I can count several of my patients are male. And number two, COVID can do a lot of different things. And in this case, COVID was the center of this condition. And this type of event probably won't happen often in outpatient setting, but it's just a reminder that the COVID can do so many complications, including this. So asking questions alongside what medication do you take that may cause intracranial hypertension, and your obesity history, sleep apnea, and asking about the COVID history may actually be helpful for you to understand what's going on. And lastly, I think whenever we refer our patients to the primary care provider or the ER, they oftentimes ask, okay, doc, what do you want? We often said the imaging, MRI, and the lumbar puncture, but we always have to make sure that we also add venogram, because thrombosis, venous thrombosis and stenosis can be associated with intracranial hypertension. And just like this case, that could be really critical in the diagnosis and management.
Okay, those are all very great tips. Thank you so much for joining us today, Dr. Kanai.
Oh, thank you for inviting me over.